Hi friends, this is again a second session for a Bailey high yield discussion. Just join the discussion. I will share the screen. I hope all of you are in full swing preparation. I always tell just keep going. Don't bother about government decisions or like which is happening, which is outside our control. Please don't give importance for that. Just a few seconds, media. See, I'm not able to share the screen. We'll go to the points. The most common cause of death in surgical patients. What is the most common cause of death in surgical patient? Any guess, my dear friends? So it is a shock. Shock is the most common cause of death in the surgical patient. Remember that. And for the distributive shock, there are three causes of distributive shock. Remember it as SA and SAN. One is like septic shock. Number two is anaphylactic shock. Number three is a neurogenic shock. These three are three conditions which presents as a distributive shock. Okay, SA and SAN, septic shock, anaphylactic shock, and neurogenic shock. The third point you have to remember is endocrine shock. In endocrine shock, it presents with either it can be a combination of hypovolemic shock or distributive shock or distributic or anaphylactic shock. So it can be asked as a question. So endocrine shock can be a combination of a hypovolemic shock and distributive shock. So it can be asked. And if if a blood flow to the brain, lung, and kidney is restored, okay, is maintained in a patient with a shock, then it is called as a compensated shock. So a compensated shock can go for a decompensation. So if blood flow to the in a shock patient after resuscitation, if a blood flow to the brain, lung, and kidney, brain, lung, and kidney, or restored, it is called as compensated shock. So occult hypoperfusion. Remember the point when there is a more than 12 hours, when there is a more than 12 hours of occult hypoperfusion, there is a chance when the reperfusion is started, the patient can land up in injury. Okay, so reperfusion injury, the patient can present with acute lung injury or acute kidney injury. So hypoperfusion more than 12 hours is dangerous. So the cutoff is more than 12 hours. Hypoperfusion more than 12 hours is a dangerous one. So what is the difference between multiple organ failure and septic shock syndrome or sepsis syndrome? More than or equal to 2 organ failed. Remember, more than to equal to 2 organ failed is a multi-organ failure. More than or equal to 1 organ failed is septic syndrome. Along with the sepsis will be there. So septic syndrome is a combination of sepsis plus more than and equal to 1 organ failed. Okay. And these 2 points I really love. Response to the fluid challenge. So response to the fluid challenge, how to remember the response to the, how to assess the response to fluid challenge is central venous pressure. So when a patient is in a shock, when blood is being replaced for the blood loss, so when the CVP raises, it shows a response to the fluid challenge. And number 2 important point is adequacy of the perfusion to the organ is how will you assess, yes, this patient after the shock has been adequately perfused. So perfusion indicates, for example, perfused to the kidney, the urine output. So the urine output indicates a measure for adequacy of perfusion of the organ after the shock. Remember that point, my dear friend. So perfusion response to the fluid is CVP. response with the perfusion is urine output. So this point is being again and again asked, what is a clinical indicator of GI perfusion or muscle perfusion? So GI perfusion or muscle perfusion, the clinical indicator is mixed venous saturation or base deficit, lactate and base deficit. How to assess a mixed venous saturation? So mixed venous saturation you measure by when it is less than 50%, it indicates there is a shock. Whatever the shock tissues take all the oxygen. So it is one possibility. So when the mixed venous saturation is more than 70%, it indicates there is a high output shock, like a septic shock or a disruptive shock, in which there will be more amount of cardiac output will be there. When the mixed venous oxygen saturation is more than 70% is septic shock. Less than 50% means there's a tissues which needs oxygen. That's the reason it takes whatever available oxygen. So whatever, when it goes into the blood circulation, into the venous circulation, it becomes less than 50%. And trauma-induced coagulopathy. To remember trauma-induced coagulopathy, the three components. One is lactic acidosis, hypothermia, and coagulopathy. So this is a triad. When it is not stopped, the patient can go for all complications because of this. Okay, this is the principle which we manage in damage control surgery. So don't allow the patient to get into this triad. So remember it as CLH, coagulopathy, lactic acidosis, and hypothermia. So this is a very good point. Next point I can say is a clopidogrel. So clopidogrel, when a patient needs acute reversal for clopidogrel, what to be given is platelet, or you can give AVP, arginine vasopressin, or D-desamino arginine vasopressin, DDAVP. So either you give for clopidogrel reversal, acute reversal, give a platelet, or you give a AVP or DDAVP. For warfarin reversal, you give prothrombin complex concentrate. So for latest Bailey says for warfarin reversal, what you give is a prothrombin complex concentrate. Sorry. Next point, the often asked cryoprecipitate. The storage happens in minus 30 degrees C, fresh frozen plasma, minus 40 to minus 50 degrees C with a 2 years shelf life, and prothrombin complex concentrate. So it has a rich in, so prothrombin complex concentrate. So prothrombin is factor 2, first pinch. So P stands for prothrombin. There's a mnemonic, a little bit A kind of mnemonic. Okay, so I don't get into the entire mnemonic. So prothrombin complex, first pinch. So first for fibrinogen, prothrombin for second. So factor 2, factor 9, and factor 10 rich in prothrombin complex concentrate. For cryoprecipitate, it is rich in factor 1 and factor 8. Cryoprecipitate, factor 1 and factor 8. Prothrombin complex concentrate for warfarin acute reversal, and clopidogrel sorry friends, sorry for the net issue. So for warfarin reversal, you give a prothrombin complex concentrate. For clopidogrel reversal, you give a platelet or arginine vasopressin. Okay. Next is abiotic. So abiotic is synthetic oxygen carrying compounds. Remember perfluorocarbons, which is second generation in the abiotic, they can ask. And transfusion associated lung injury is fresh frozen plasma is usually associated with transfusion associated lung injury. I hope you guys enjoyed the session. All the best. Just keep going. Don't bother about what Supreme Court will tell on Monday. For this given day, you prepare. It is like the facing stress of exam or stress of anything is preparing or facing every day. I can say rather every second, every minute, every hour, and every day, rather than next day or what next after a week or what next happen coming Monday in a Supreme Court verdict. Don't bother. Today you have prepared nicely. Sleep well with that energy. Definitely with your preparedness alone will happen. Don't worry about whether to read Urology Campbell or Greenberg or Devita or X or Y or Z. Just read Bailey and Love as of now. If suppose something happens like a previous super specialty plus Bailey comes, then you have you can read in upcoming days with urology. So or super specialty topic. So as of now, what you should do, read Bailey, nothing only but Bailey and Love. All the best. Jai Hind. Bye.